Hey, my name is Abhishek Kumar, and I'm reporting live from the SMIS 2021 meeting in Las Vegas. And today I'm going to be talking to you all about finding efficiency in MIS TLIF. So the goals of this talk are going to be to help you reduce your radiographic time, reduce your time under anesthesia, and get more consistent results with this procedure. So I'm going to share a couple tips and tricks that I've kind of weaned out for myself and also that I've learned from my senior colleagues. So first of all, when you're doing this procedure, what I like to do with my initial incisions is to converge those together through single 22 millimeter incisions on each side. So if you line yourself up from the superior pedicle, press a tube into the skin, and have that 1 centimeter lateral to each of your pedicles, you're going to bring those two together and you're always going to be able to fit both your screws down there. The next key thing is you want to be able to flip your C-arm only once. So you're going to localize yourself with your fluoroscopy beam parallel to the superior end plate, and you're going to watch as your jam sheety advances. First segment should be just 1 centimeter in, at which point you should be about halfway across the pedicle. Second centimeter down, you're going to make sure you're just lateral to the medial border of the pedicle. And so when you flip to lateral, you're going to find that all your wires are well placed without having to flip back and forth. The next step is placement of the tube. And so after placement of the wires, you're going to localize your tube. You want to dilate that up and then confirm positioning in the lateral, because that's going to guide you for your 3 steps of orientation. So the initial step of orientation and maintaining your localization in the MI TLIF is to identify, obviously, your joint line. So you can expose that with the bovie, and where you want that to line up typically is on your lateral third of the tube. That's going to ensure that you have enough space for the inferior facetectomy, and you're going to see all of the superior facet remaining, which can be resected and get you right down to the right spot. So as you've done your inferior facetectomy, you're watching the joint line, you're going to amputate your superior facet just in line with this junction at the pedicle. And from your initial lateral shot confirming your tube position, you can see and line up where that's going to be on your tube. So once you've burned down from there, you can take a couple extra bites if necessary with your kerrison just to bring it to the pedicle junction. And where you really want to go next is take a bite and slide medial to the pedicle. So now you found the medial border of the pedicle, and you know exactly where you're going to be in terms of your convergence to get that cage nicely midline. That's your second key landmark for keeping it oriented in the MI TLIF. From there, you're going to make your annulotomy, and you're going to sequentially size up with your shavers or distractors. I find the easiest way to do this is just with hammer blows from my own hand. And again, that way you're going to prevent any kind of breach through the anterior annulus. And each sequential time as you're sizing up that way, you're going to follow that same path. And you can actually measure your depth based off of the numbers and writing that's on each shaver. When you line that up with your tube, you're going to know your depth, and you're not even going to need to take a fluoro shot to know exactly where you are. The other key thing for the discectomy is once you've sized yourself up, you've gotten some good bite as you turn that shaver, you want to bring that back a little bit so you're actually pushing it up against the posterior margin of that vertebral body. A lot of people spin that right deep inside the disc space, and you're not going to clean that end plate. You're going to leave a cartilaginous surface on that. Once you've achieved a good discectomy, you're going to want to focus on the contralateral side, of course. So the best way to do that is with your shaver. Once you've sized it perfectly, you're going to bring it out, you're going to pass it again, more convergent, so you get to the contralateral side, and also neutral, so you get the ipsilateral side. From there, I like an upgoing pituitary to get to the contralateral side and create a trough. That trough's going to allow access for an angled ring curette, and even a rasp I like to use as well to clean that contralateral side nicely. That's going to allow you to get a good articulating banana-style cage in there, and that kind of cage will get you right up anteriorly against the apophyseal ring, which is going to provide you with the most support and minimize your risk of subsidence. Pre-packing is incredibly important beforehand as well, and then packing that cage in is going to compress all that bone graft, and that's how you're going to get good fusion rates. From there, you're going to turn back to your screws, and again, tapping down each wire can be done with minimal fluoroscopy use if you really let the tap self-center itself and do it in a sequential fashion and follow the amount of resistance you're getting. Once you get a good bite, you're typically right there at that pedicle vertebral body junction, and you're going to pass that back with good downward pressure on the wire to prevent that from coming back. Placing screws over top afterwards is going to take some fluoroscopy shots to confirm your depth and know when to retract your wire, but you can save another shot from measuring your rod and utilizing the length of the screw. You can kind of extrapolate that to select the right size rod, which saves you a step as well. So by combining all these steps, you're going to minimize your radiographic time, you're going to maximize your reproducibility of this procedure, and you're going to minimize operative time for better results. See you all next time.